I just have gone ahead and started the recording, and we'll trim it down after.
Okay.
And we're in
Yeah,
business.
854.
That's the right one.
Yeah,
Thank you for confirming.
sure.
With that, I will mute myself, and everybody except for you are muted.
Okay.
Okay. So do you want to advance it here? Do you want to remote control?
Whatever is easier.
Okay.
I can sit there if I'm able to just see everyone. Okay.
And they just have breakfast, coffee, juice, water, if you want.
I need to go get some coffee.
A cancer diagnosis sets off a catastrophic tidal wave of fear, anxiety, and confusion. In one moment, your life story is divided into two chapters: before cancer and after cancer. And you'd give anything to go back to chapter one. I was diagnosed with cancer in December 2003, 2 days before my felt like a death sentence. From there, it was a whirlwind. I was rushed into surgery afterwards. They said I needed 9 to 12 months of chemotherapy, and there was a 60% chance of being alive in 5 years. I realized my body created
Okay.
the oncologist told me I was insane. Most of my family didn't understand. I was very much alone. But I was determined to live. So I started reading and researching like crazy. Every therapy I could find.
Shot that the mandate stage shot during his lifetime by other people about the time during which he lived. So they had a huge number of faith. I will say another second. Really great junkies.
It's called Square One. This course will take you step by step through the healing process. It will eliminate the fear and confusion and show you exactly where to start and give you a roadmap to radically transform your life through health. And I'm giving you free access to the entire course, all 10 modules. A caregiver, or if you're serious about prevention, this course is for you. Square One is where to start. Tune in to watch the entire Square One Healing Cancer Coaching Program free online.
Dennis?
Starting August 13th. Enter your name and email on the
Yes,
free access.
I can hear something in the background.
I do. I hear it. I'm hearing it at the PC that's there. Is Tony nearby?
Let me see. He's probably sitting in the room next door.
Oh, yeah. It's really incredible. Yeah, and so Natasha, early, the parents came, they stay with us father is an engineer.
No, actually, Dennis is asking for you. I don't think it's.
So he went to Boston, and now he lives in
Hello, Dennis?
Hi, Tony. We seem to be hearing, I don't hear it right at the moment. It seemed like,
Yeah.
It's probably my phone. Let me go hang up mine, okay? Hold on.
thank you. Oh, hey, Tony? Tony, just mute your phone.
Okay.
so we will visit Natasha.
Okay, how's that?
I'm hearing the more.
Are you there?
Yes, I am. I was muted. I'm not hearing anything at the moment, but check your phone periodically. If anything happens, I'll let you know. Thanks.
Okay.
Thank you.
Are we good? Okay. I think Monica thinks it's all right. So we're good. I'll just turn it down here a little bit. There we go.
Thank you, Tony.
Okay.
Natasha had very, very creamy. Nothing wrong with it.
Good morning.
I'm the position liaison for Ashley. I just want to introduce myself, Cindy.
Hi.
Nice to meet you.
Nice to meet you.
Radio has to go through the tree line starting at.
Oh, no, we have to go somewhere else.
Sorry.
And maybe it's like charging you for it, maybe.
No.
But meeting what you were sending you the deal for that, way back,
That's the Natasha.
Huh?
basically charged me for it.
Really?
Yeah.
No, they're supposed to, we have it set up so that you just go through the cafeteria tray line and charge it to the MSO. And so you have to just get there a little earlier.
I think it was from 7 months. Yeah. She
But they really know, okay?
Just, it was less than 25 people.
Can we pat it?
So where do we have to go?
To the cafeteria.
And when you go through the cashier, you let them know that you're attending the pediatrics conference, and you don't have to pay.
Why is that? Why is that?
Well, they're saying that it's too expensive to cater down here for less than 25 people, so it's cheaper to just go through the tray line. Well, unfortunately, that's what it is. Because if I include the people that call in, it's about 25 people, but they're not here physically. So.
We should do it after breakfast.
Yeah. Well, but then you have a variety. You can get whatever you want. They have pancakes or waffles or whatever they have, instead of just the same. No, the meeting's going to start at the same time. You guys, the important people, as you like to say, will be late. Because they'll be in the tray line. So.
You let me know when I have to start.
Actually, you can start now. Yeah. And people will trickle in.
And let that last person who went to get breakfast come in. Can you see how many people are logged in?
Yeah, I started.
Can you see how many people are logged into this?
Yes. Yes. Right now we have 7 people logged in. Okay.
Should we wait for one person or should we go? All right. Good morning, everyone. My name is Monica Silver. I'm a pediatric endocrinologist with prescription phone health. It doesn't necessarily fall under endocrine. However, somebody has to take care of the kids. And so in different facilities, different people, it falls under nephrology sometimes. Geneticists take care of it. Endocrinologists do it. And so it's kind of a shared field. So I have nothing to disclose except that I would like this to be an interactive session. We'll have 5 cases, and I would like people to, answer questions and ask questions. Okay? Okay. So what are my objectives? I would like to describe factors that affect optimal health in children, recognize the children who are at risk of developing osteoporosis, and review the latest guidelines for treatment and diagnosis of pediatric osteoporosis. The first question is, why should we care? This is a disease of old people. As a pediatrician, we don't have to worry about it. However, really, the foundation is built in childhood and teenage years. And so we should care. Also, it's not just a disease of the elderly. It is actually in children. There are children with osteoporosis that are under-recognized, and that we can actually do something about it. So with prevention or early intervention, we can make a difference. So we should care. From birth to adulthood, like 40-fold increase in your bone mass, and okay, I guess it's not going to show up.
Yeah, you can use the keypad.
It doesn't show up. Okay. Well, basically you attain your peak bone mass by your early 20s. You have a little plateau, and then you start decreasing your bone mass with age. Of course, the decline is more rapid in women due to menopause. And if you have a reduced peak bone mass, you actually have higher risk factor risk. And even a 10% increase in peak bone mass will reduce the individual's fracture risk by almost 50% and delay postmenopausal osteoporosis by almost a decade. And so it is important that we pay attention to the peaceful mass. So we're going to start with case number 1. This is an 11-year-old girl who slipped on the kitchen floor and broke her femur, distal femur. She was seen in the emergency room. Orthopedic surgeon did not feel a surgery was needed. A cast was placed. And she's there for follow-up in your clinic right now. You review her chart and you see that she had a fracture of her tibia around age 4. She fractured her radius around age 6. And they were all with minor, pillow fight disciplines at home. If you do a very thorough exam and you see that really healthy-looking child, teeth look fine, sclera looks fine. So the question is, how many fractures are too many when these work? So how many of you think this is normal childhood, the normal childhood fractures? No. You worry about the child? Yes, looks like no. Okay. So fractures are common in childhood. A third of the children will fracture one bone. Most common is the radius. Usually running all on their outstretched hand and they break their radius. And you get a peak in the teenage years. Boys peak is higher than girls. Fathers have risk-taking behavior. And actually, the incidence of forearm fractures in a 13-and-a-half, 14-year-old boy is equivalent to that of a post-about. The other reason why we think in teenage years you are at a higher risk of developing fractures is because, I don't know if you guys can see the slide properly, is because you get your pubertal growth spurt and you accrue bone mass. However, the mineral accrual is delayed as a lag, usually follows the peak height velocity. And so there's a year of lag of low bone mineral density, and that increases your risk of fracture. And so, as you expect, girls tend to have puberty earlier than boys, and so the peak age of fracture for girls is around 12, whereas it's around 14 for boys, similar to the pubertal pattern. So forearm fracture, as we were talking, very common in somebody with a normal bone, followed by humerus, followed by tib fib. However, when we look at somebody with femur fracture or vertebral fractures, we're really thinking that this is an osteoporotic bone. And this is bone fragility, and it needs to be evaluated. Now, of course, I'm not talking about somebody who was in a major motor vehicle accident and broke their femur and spine. I'm talking about normal injuries that you expect in children. So why do children get osteoporosis? They're not small at all. So it's not the same as, in terms of bone loss. It's more because they have failed to gain bone. So they fail to gain the bone size, shape, and growth. Of course, they can also have loss based on, depending upon what kind of chronic medical problems they have, what medications they have, but the major reason is inadequate gain. Okay, we're going to move on to case number 2. This is a 14-year-old healthy girl whose mom was recently diagnosed with osteoporosis. The mother had a DEXA scan, and she got a report that she had osteoporosis. So she requested her OBGYN to order a DEXA for her teenage daughter. She got a DEXA scan done, and it was read as hip and spine, a T-score of minus 2.1, suggestive of osteopenia. They are, of course, in your office now because they want you to do something about it, because her daughter has osteopenia. Review her chart. She has a past medical history of a traumatic radius fracture at age 8, running on a soccer field. No family history of fractures. Even mom, who's been diagnosed with osteoporosis, has never broken a bone, and her mother, so maternal grandmother, has never broken a bone, and no history of osteoporosis on dad's side of the family either. She actually has a good diet. She's an active girl, and now, of course, she's taking a daily calcium and vitamin D supplement. So and she attained menarche at age 12, and she has regular menses, BMIs of the 50th percentile, exam is normal. There's nothing else in her past medical history or her current review of systems that's worrisome. So how will you explain the DEXA report to the family? How many of you agree that she has osteopenia based on the DEXA report? You don't think she has osteopenia? Is the DEXA report abnormal with a T-score of minus 2.1? No? Okay. So, you're right, it's complicated. It is really challenging to interpret. First thing is that HIP is not the preferred set in a growing trial. Landmarks are difficult to place, even in adults, and in pediatric population it's even more difficult. Spine and total body left head is what we want to assess. Spine gives us an idea of the trabecular bone, total body gives us more of an assessment of cortical bone. Second is it's a moving target. These kids are growing, they're going through puberty, a lot is changing. And so assessment can be challenging. And third is that the chronic diseases, which we'll talk about in a little bit, that affect the bone, also affect growth and puberty. So that complicates matters even more. T-score is not the correct score for assessing bone mineral density in a growing child. So that report said a T-score of minus 2.1. We never look at a T-score. So that report is not going to be valid. What we look at is a Z-score, like we do for other things. It's a standard deviation from mean for age, sex, ethnicity, and actually varies based on what kind of reference data you use. You can't compare one to the other, and you cannot compare a Provosic DEXA to a GD-Lunar DEXA. So you have to be careful about
you should see it, so we send it, Dennis should see it, we send it to everyone.
On the same machine. They have to use the same reference data to correct. And then you have to actually correct for body size and maturity. So that GERD was at the 50th percentile. However, if somebody is short, you may underestimate their bones because they have smaller bones. It's aerial bone mineral density. Somebody is tall, you may overestimate their bone mineral density. You have to correct for bones, for body size and maturity. So a 14-year-old with puberty, whereas a 14-year-old who's done with puberty are not the same. So lots of variables here. Sexual reports not use the term osteopenia. It should not use the term osteoporosis. If you're going to get, it should just say a Z-score of whatever it is. And if it's less than -2, -2, it is termed low bone mass per age. It should not say osteopenia or osteoporosis. And the reason for that is there is really no pediatric fracture threshold. We don't have the kind of data that is available in the older people that says if your T-score is less than -2.5, your 10-year fracture is just X, Y, and Z. We do not have that. We actually do not see that. And on the flip side, we actually do see fractures occur completely normal bone mineral density, especially if somebody is on steroids. And so just because a BMD is normal or abnormal, it doesn't tell you anything about bone fragility. So we moved away from just getting DEXAs or, following DEXAs. We are looking more at the clinical history at this point in terms of fracture history. Okay, case number 3. So this is a 12-year-old girl who was presented to your office 8 months ago with weight loss, fever, myalgias, and then you did a thorough workup, ended up with a rheumatologist who diagnosed mixed connective tissue disease, got started on prednisone, 15 milligrams daily. This has improved. She's doing much better. However, 3 weeks ago, she started complaining of lower back pain. She does not think she fell. We call it a history of trauma. An exam, she is tender in her lower spine, so you order a spine X-ray, which is read as vertebral deformity, the T12, L4, and L5. So what is the cause of the back pain? She has these deformities. Do you think they may be causing pain? Compression fractures, that's right. So compression fractures are sometimes read as deformity. So your radiologist really needs to be on the same page in terms of if you have a suspicion of, if you're worried about compression fractures, you should write it out and they should look at it carefully. And the way it's graded, okay, I can't use a pointer. However, that's most. See, the anterior height of the vertebra is less than the posterior, and then there's grading mild, moderate, severe, depending on how much height you've lost. The biconcave, in which the middle kind of gives in, you have a crush injury. This is how you describe, and then you can quantify it in terms of the number that are affected and the severity, and you can come up with a spinal deformity index. And the reason this is important is there is a linear relationship between baseline spinal deformity index and your 3-year incidence. So if you are at a higher score early on, you're likely to get more and more fractures. So pediatric osteoporosis, based on the latest guidelines, is a clinical diagnosis. If you have vertebral compression fractures, which you cannot explain based on trauma or a localized infiltrative disease, whether you have a low mineral density or not does not matter. You meet the criteria for defining this as pediatric osteoporosis. If you are not dealing with compression fractures, but you're looking at long bone fractures, if you have 2 or more by age 10, 3 or more by age 19, with low bone mineral density, that would qualify as pediatric osteoporosis. First, genetics, like up to 60–70% of your bone strength is determined by genetics. That's why getting a family history is very important. But then there are other factors, malnutrition, both under and overnutrition, inactivity, and I'm not talking about just sedentary lifestyle, I'm talking about kids who are immobile, different disorders, hyperthyroidism, hyperparathyroidism, hypogonadism, all these things can affect your bone strength. Inflammation wreaks havoc on your bones, and drugs that we use to treat the inflammation is even. So when you say primary osteoporosis, we're talking about you actually see a genetic issue with your bone protein, your collagen, or its processing. And the most common and most familiar thing is like OI. When we talk about secondary osteoporosis, we are looking at anything else that is affecting your bones. So immobilization, children with difficulty, muscular dystrophies, chronic diseases like CF, IBD, malignancy, rheumatological disorders, eating disorders, and then medications that are used. The glucocorticoids are notorious, but also Depo-Provera and anti-epileptics. So ideally, what we would like to do is treat the children who are at greatest risk before they develop a fracture, so primary prevention. And of course, we don't want to treat those who we know are going to recover spontaneously, but we don't know them because we have not identified these kids and we have not followed their natural history. For primary osteoporosis or OI, we still have more data available. However, still, genotype-phenotype correlation is not available. It's not that straightforward even for OI. Even in the same family with the same mutation, quite a bit of variability in their presentation. So we really don't know. So there was a multi-center study done. Around 12 centers participated in this in Canada. It was called STOP Consortium for Steroid-Induced Osteoporosis in Pediatric Population. And it was an observational prospective study for 6 years. And they looked at 3 major diagnoses: ALL, rheumatological disorders, and nephrotic syndrome. They enrolled a pretty wide 1 month to 16 years. Anybody who had their first time IV or oral glucocorticoid initiation. So ALL, they recently published their 6-year follow-up data. They had close to 200 kids, and what they did was they did annual spine radiographs. So at baseline, at the start of glucocorticoids, they did their lateral spine X-ray, and then they did it every year. They recorded any low trauma long bone fractures of non-vertebral fractures, the VF is vertebral fracture, and they did DEXA scans every 6 months for the first 4 years, and after that annually. And what they saw is a third of the kids had vertebral fractures, out of which almost 40% were asymptomatic, did not have any back pain. The reason why they picked up these kids is because they were doing annual radiograms. A quarter of the kids had long bone fractures, and most of the fractures actually occurred in the first 2 years. But the interesting thing is 16% had fractures at diagnosis before steroids were started. So it's not just the steroids, it's also the disease itself. And when they followed these kids, what they show is the first arrow, down arrow, it shows the start of chemotherapy, and you can kind of see the grades getting worse. Once the chemotherapy stopped, there is some recovery spontaneously, and then as the kid grows and goes through puberty, there is actually some reshaping. It doesn't show up that well on the screen. There is some reshaping of the bone. However, only a quarter of the kids had some reshaping, and you had persistent residual deformity if you were older at diagnosis of ALL and you did not have the growth potential left. So you were post-pubertal. You were late in puberty when you were diagnosed. And of course, if you had a higher spinal deformity index at baseline, you had incomplete reshaping. So the question is, should we intervene in the first 2 years of chemotherapy, because that's when you are seeing most of the fractures, Should we intervene if this is an older kid, but maybe if this is a 2-year-old, we don't need to do anything because we know they'll grow, reshape their bones? These are all questions to be answered. The other cohort that they saw, and they published their 3-year follow-up data, is they had kind of lumped together rheumatological diseases with around 130 kids, and they saw that 12% of them had a 3-year cumulative incidence of 12% for vertebral fractures and 6% were present in the first year. And again, around 40 to 50% were asymptomatic. They did not complain of back pain. So what they saw, the factors that predict an incident for vertebral fractures, of course, if your disease, is worse, lupus is probably worse than, a JIA. It's your glucocorticoid dose, both daily and cumulative. Duration of therapy, the highest is the first year of treatment was the highest incidence. If you rapidly increase your BMI Z-score, which happens often when you put these kids on steroids, if you decline your BMI Z-score, presence of back pain does point towards that you truly have a problem. However, again, remember 40% were asymptomatic. And again, if you have a higher SBI score at baseline, you're more likely to have a worse outcome. Okay, case number 4. So this is a 12-year-old African-American boy who's an X25 weaker. He's non-ambulatory, he has developmental delay, he's G-tube dependent. Gently bathing and dressing him, he has had one severe fracture in the past, now presents with a radius fracture. He is malnourished as expected. Carefully examine, you do not see any features of rickets, and you look for bruises in terms of, any suspicion of non-accidental trauma, and you do not see that. You get some labs, there's a normal CBC, ESR, calcium, creatinine is low, but normal for the muscle mass. Alkaline phosphatase is elevated as expected in the setting of an acute fracture, and 25-hydroxyvitamin D is low at 3 nanograms per ml. So what do you think is going on here? Is this due to vitamin D deficiency? How many of you think vitamin D level of 18 can cause fractures? Okay. So it is a confusing case. So this could be because the kid is malnourished. He definitely has a lot of risk factors. He's non-ambulatory, right? He was a premature baby. He's G-tube dependent. His weight, BMI is at the 3rd percentile. He's also at risk for non-accidental trauma, and he has a low vitamin D. What I did not tell you is that his serum phosphorus was 2.1. The reason I did not tell you that is because when you order the first set of labs, a comprehensive metabolic panel does not include the phosphorus. So when you are looking at a problem with, you're trying to figure out what is the cause of fractures or rickets, you really have to look at the phosphorus as well. So just remember to order a phosphorus level. And a magnesium is also not part of it. And magnesium is important for release of parathyroid hormone. So this kid actually had a low serum phosphorus and an appropriately low urine phosphorus. So his kidneys were doing everything to hold on to all the phosphorus. And for some reason, he was on a low phosphorus. Nobody knew why. Normal range would be like 3.5 to 5.5. Mm-hmm. So he really had nutritional rickets. And when we look at rickets, it's kind of similar to what we were talking about in the teenage years. You have a growth spurt, you don't mineralize your bone, and that's kind of what you're looking at here. You have a lot of unmineralized bone matrix, and that causes bone fragility, and that can be because of vitamin D deficiency. So usually don't see it with an 18, however, you can see rickets and osteomalacia and with low vitamin D, low calcium, low phosphorus, chronic liver, kidney disease. And then genetic causes, so hypophosphatemia is when your alkaline phosphatase enzyme is defective and you do not mineralize your bone, or hypophosphatemic rickets where you have renal wasting of phosphorus. This is a kid who actually presented to our clinic in May. It's a 13-month-old with a funny crawl and swollen wrist, and the PCP appropriately, thought of rickets, but an X-ray classic rickets showing cupping, flaring and fraying of the metaphyseal ends, very classic. And the thought was that, mom took prenatal vitamins, the kid is on vitamin supplement or was prescribed, and so this must be something rare. However, no, it was just plain simple vitamin D deficiency. 25 hydroxy of less than 10, because they were actually not giving the vitamin D. So when we see kids in our clinic and we are trying to work them up, we get a very extensive history in terms of their diet history, in terms of activity, medications. Fracture history is very critical both in the patient and the family. We get comprehensive labs. Of course, we don't order everything in everyone. However, just stand to remember that FOS and MAG is not part of your comprehensive metabolic panel, and you have to think about it. Also, celiac disease, if you can't identify anything else, if there's family history, this is a Caucasian population, I will likely get a celiac. And then our first patient where they had the femur fracture, the tibia fracture, and the radius fracture with sulophytes, probably will need a genetic workup. In terms of radiograph, the point I want to get across is DEXA. Whether or not you order a DEXA, that's fine. However, if you're going to order a DEXA, it needs to be read properly, and if you're going to follow a DEXA, order it at the same center, the same machine, the same software, just remember to do that. And if they come with a DEXA from outside, you have to be very careful, one, whether it was really the landmarks were identified correctly or not, and how it was read, what reference data was used. But whenever we have suspicion of osteoporosis, we get a lateral spine X-ray, and we are looking for the silent fractures, because that will change my management. If I have a kid with silent vertebral compression fractures, that's pediatric osteoporosis, and I'm going to start that patient on treatment. That really changes my management. So for management, genetics is something you really can't do much about, but you have to really address all the other risk factors. So you have to look at their nutrition, activity, and their primary disease. So case number 5, this is a 16-year-old girl. She's a cross-country runner. She attained menarche at 12, had kind of irregular periods, but now has not had a period for a year. She has had only 1 foot fracture. So does she have osteoporosis? Only 1 foot fracture. No. Based on the criteria that we talked about, she does not have osteoporosis. Okay. Mom, of course, demanded a DEXA. You got a DEXA scan, which was read as fine, aerial BMDZ score of minus 1.8. So does she have osteoporosis now? Is the Z-score a correct thing to use instead of a T-score here? No? Yes? Yes. What about a Z-score of minus 1.8? Is that abnormal? Is that low bone mass density, low bone mineral density for age? So less than -2 is considered low bone mineral density. Okay, so what is going to be your first line of management treatment? What are you going to do? This is a cross-country runner who has 1 foot fracture, probably an overuse injury, but she's not had a period for a year. So BMDZ score is fine. Are you going to start her on a bisphosphonate, which is a treatment for osteoporosis? Okay, but most of you said you're not going to start her on the drug. What about putting her on some birth control pills? She's 16 and she's not had a period. No? Okay. What about putting her just on a transdermal estrogen? Transdermal estrogen absorption is better than by mouth. Nobody wants to give her estrogen? Okay. Okay. So, yeah, nutrition counseling. So, getting her a detailed dietary history. What about calcium, vitamin D supplementation? Okay. Okay, that's what it is. Okay. So, likely she's a runner. She's probably getting, calcium and vitamin D supplements because she's probably a vegan. I'm just kidding, but a lot of them are. Yeah, you're right. Nutrition counseling will be the first line. This smells like disordered eating, or at least you need to evaluate for that. So remember, when we think about the female athlete triad, or even, there's male athlete triad, we're looking at the red. So they have either, low energy availability with or without an eating disorder. They have functional hypothalamic amenorrhea and osteoporosis. However, there are lots of kids on that spectrum in that black blue area, and you need to evaluate these patients with high index of suspicion. So nutrition counseling is going to be the first thing. Okay, calcium intake. How much calcium do the kids need? They need more than what they're getting, most of them. Whenever I ask, most of them don't drink milk, and they may have yogurt and cheese a few times a week. Teenagers especially need almost 3 servings of dairy a day to meet their RDA of calcium. They need 1,300 milligrams of calcium, And we're looking at elemental calcium here. You can get around 300 from your regular diet. Each serving of dairy is around 300 milligrams of elemental, so actually they need 3 servings of dairy, and most of them are not getting it. So one of the basic things to do is counsel how much calcium is needed. Some of them just cannot eat dairy. Of course, you have other sources. Is much larger. I will sometimes prescribe Tums or tell them how much to take. If they cannot do it with natural sources, you don't want to overdo calcium as well, because your kidneys are very smart. They're going to spill, and you're going to get kidney stones. And so you have to be careful about that. For vitamin D, I don't know what is the normal range that you guys have here and what you like to use. Everybody seems to have a different cutoff, and the Institute of Medicine says it should be over 20, and the Society says it should be over 30. We're happy if everyone is over 20. What we don't like to see is when kids like with Duchenne muscular dystrophy with like multiple risk factors for their bone come in with a vitamin D level of 8 to our clinic. That's what we don't like to see. And everybody uses different ways of treating vitamin D deficiency. I will give 50,000 units a week for 6 to 12 weeks to somebody who's less than 15. Somebody may use a different cutoff. But remember, some kids with malabsorption, cystic fibrosis, obesity will probably require higher doses. Okay, skeletal loading. So like I was talking about, if you are moderately active or you may have a slightly different bone mineral density. If you do high impact loading, like jumping, weight bearing activities, you get an increase in bone density. However, we are worried about those who are completely immobile because they drastically reduce their bone mineral density. And not just bone mineral density, they actually have their bone geometry. Okay, so this is, you're looking at cross-sectional view of your long bone. So there is something known as a peripheral quantitative CT. Basically, you can put your forearm or your leg in it, and you can get an assessment of the cortical bone or the trabecular bone. So this is looking at the cortical bone, and what these kids have narrower bones. They have thinner cortices, and that's because they do not lay the bone on the outside. The periosteal apposition does not happen, even though they don't have a difference in length or a volumetric bone mineral density. And the fracture incidence is 25% if they're non-ambulatory, and over 70% of that happens in the lower extremity. So your lower femur, your distal femur, proximal tib fib is the most common side. And Duchenne muscular dystrophy, again, 20 to 60% will fracture their lower extremity, and 30% have vertebral fracture with back pain. But we may be missing a lot who are not complaining of back pain. This is a report, again, from Canada, Leanne Ward, who was the PI at that STOP consortium. She is looking at kids with Duchenne muscular dystrophy, and she shows that it's an 11-year-old boy who was started on glucocorticoids, and you can see the grade worsened for your vertebral fractures, and there was sort of IV pimidronate, and with puberty there is a little bit of reshaping of the bone, but there is really incomplete reshaping in these kids. Treating the underlying disease like an inflammation. So this is a study of 90 patients with Crohn's disease. Instead of giving them glucocorticoids, a biologic agent was used. And this is again looking at the peripheral quantitative CT on the tibia. And what they saw was that in 1 year, they actually had increased in cortical thickness and trabecular density. So kids who are younger and growing can actually gain bone. And so that's very optimistic. And also they did not use steroids. So that's pretty good. Okay, so if you can't, improve with nutrition, activity, treating the underlying disease, we do have some pharmacological agents, but they are not FDA approved. None are FDA approved. There are anabolic agents for bone, is growth hormone and PTH. We do not really use it. PTH actually has a black box warning. So there's a risk of osteosarcoma in rats that was seen, and the thought is that because they have open growth plates. However, we don't know if it translates completely into humans. There are studies looking at PTH for children who actually have hypoparathyroidism. So maybe once we see that, hopefully we could potentially use it for bone as well. Anti-catabolic agents, we will replace with steroids if they're hypogonadal. and bisphosphonates will go over that, and denosumab is another anti-catabolic drug that is actually in trials for pediatrics. So bisphosphonates is basically, once you administer it, it gets laid on the bone surface, it's taken up by osteoclasts, which are your bone resorption cells, and they cause apoptosis of the osteoclasts. And so osteoblasts, which are the bone-forming cells, continue to work, and you probably have more bone and less fractures. So benefits happen. That's why that is actually the standard of care. And also in secondary osteoporosis, pretty much everything except in disorders. But most of the studies are uncontrolled, small cohorts, looking at bone mineral density rather than fracture data. And there is really no head-to-head comparison between the different drugs and dosages. So everybody has their own protocol. We have our own protocol. And it works really well. However, there is no head-to-head comparison. We do know that IV is better than oral, especially for vertebral compression factors. And there are two IV drugs, midodronic and zoledronic acid, that is used. The most common adverse effect after we give an IV is you kind of get a flu-like illness after the first dose. Within the first 24 hours, we manage symptomatically with Tylenol, Zofran, and whatever is needed. What we worry about the most is their vitamin D stores are low. You have a high risk of electrolyte abnormalities, hypocalcemia, hypophosphatemia. So we make sure that everybody has adequate vitamin D levels, 25 hydroxyvitamin D of at least over 20 before we would give the drug. And actually with zoledronic acid, we see more electrolyte issues because it's more potent, and so we've just been empirically prescribing calcium supplements for a couple of weeks after the infusion. Serious side effects, there has been no reports for osteonecrosis of the jaw in pediatrics. And then there's something known as atypical femur fractures, which again is rare in children and mostly seen only with osteogenesis imperfecta and not in patients when we're treating them for secondary osteoporosis. What about teratogenicity? This drug, once given, actually sits in your bone for decades. We counsel about uncertainties. There was some mice study which shows some defect. However, we've not seen it in humans. How long do we treat for really depends upon when the child was diagnosed, what is the reason, why are we treating, what is the primary disease, what is the alteration in skeletal geometry. We would discontinue if there were factors results. If somebody had ALL and is in remission, is not needing steroids, we'll probably not continue. Once they're done growing and they're not laying new bone, we would discontinue. If they're clinically stable, if they reshape some of their bones, we will discontinue. However, if somebody has primary osteoporosis, so like OIs, we do not give breaks until they're done growing. And the reason is that they're going to lay abnormal bone, which is not treated. And actually that creates a stress rise, and they fracture at the junction of the treated bone and the untreated bone. So a lot of our kids will come back from their orthopedic visit and ask about drug holidays because that is what is used in the adult population, but we do not do that in pediatrics. And the concept of drug holidays is don't want to over-suppress the bone because you really freezing the osteoclast, you may cause adynamic bone disease, but these kids are still growing. Maximal benefit has been seen in the first 2 to 4 years, and after that we basically have the dose or the frequency, and we will continue till they're done growing. So coming back to, our goal again, primary prevention. If you know they're at high risk, if you know that they have a baseline vertebral fracture and there is a vertebral fracture cascade, if you know that the spontaneous reshaping is unlikely and that the disease is chronic, we would really like to do primary prevention. So there's only one prevention trial in pediatrics, and it was done in Duchenne muscular dystrophy patients. It's non-randomized. They prescribed oral risedronate, which is a bisphosphonate, at the start of glucocorticoid therapy. The mean age was around 9 years. 52 kids started the drug. 9 actually dropped out within weeks of starting, and that's because taking oral bisphosphonate is not easy. You have to take it with 8 ounces of liquid. You have to sit upright for 30 minutes to prevent meningitis, and try doing that in children and teenagers. It's really hard. 36 continued for over a year, and what they were looking at was DEXAs pre and post, and they did x-rays only if they complained of pain. So we may still have missed asymptomatic vertebral fractures. The numbers are really small. You can see there were only 36 subjects and 15 controls. They saw vertebral fractures in 8% of those who were treated, whereas 33% of controls. But again, we're looking at 3 versus 5, so it's hard to say. They did see that there was not, the spine BMD was maintained, so there wasn't a further decline, and total body BNP actually increased. So to summarize, your peak bone mass is attained by early third decade. Pediatric osteoporosis is not based on just a bone mineral density. We have to look clinically, fracture history. It is actually common, as we saw with the Stroke Consortium data, that it is actually common and under-recognized in children with chronic diseases. Vertebral fractures can be silent, they're silent, and actually can predict the fractures. And that we would use pharmacological therapy if general measures fail. So we actually have a bone health clinic at Stanford Children's. You guys are familiar with Dr. Backrack and we run it, but we also have colleagues from sports medicine, orthopedics, adolescent medicine, and genetics, and so it's a team of physicians along with physical therapy, nutrition, social work, and a nurse coordinator. And what not every patient needs to see all of the whole team, but if this is an athlete, they will probably see in adolescent medicine and sports medicine. If we have somebody with an eye or other kind of primary osteoporosis, probably the orthopedic, genetics, and us. And collaboration is obviously the key. So I'm supposed to have 4 people have questions. Is everyone ready? So which of these factors warrants further workup for bone fragility? 12-year-old boy with left femur diaphyseal fracture after slipping on a wet patio floor. A 12-year-old boy with multiple thoracic vertebral compression fractures after a major motor vehicle accident. 12-year-old with a buccal fracture of left distal radius after falling while running on a soccer field. 12-year-old with fifth right metacarpal fracture after being kicked in the hand. Or a 12-year-old boy with incomplete non-displaced fracture of the distal epiphysis of the right medial malleolus, which was diagnosed on an MRI after twisting an ankle. Does everybody say A? What about B? Vertebral compression fractures? That's right. A is the correct answer. Again, we are talking about femur or vertebrae, but look at the scenario, how he injured. Okay. True or false? 14-year-old boy with delayed puberty presents to your office with a DEXA scan report with a lumbar spine T-score of -2.6, which is consistent with osteoporosis. False. Why is it false? We don't use T-scores. That's correct. We don't use T-scores. This is a 14-year-old, and also with delayed puberty. Okay. Question number 3. This is the same boy, 14-year-old with delayed puberty. Now he has actually a Z-score. You went back, he did a Z-score, and it's -2.6. Now it is less than -2. Is it consistent with osteoporosis? Why? Is a Z-score is less than -2? We don't diagnose osteoporosis just based on a DEXA scan. So, yeah. Basically, they're using the correct location, so that's fine. They are using the correct, they're using the Z-score. They can say it is low bone mass for age. And again, remember, this is a kid who has delayed puberty. For reasons, I don't know, but, he still has growth ahead of him. You cannot compare him to a 14-year-old boy who's done with puberty. And if they were not correcting for his size or his stage of puberty, you're going to get a much lower Z-score. Perfect. Okay, one last question, but I'm sure you will get that. Young female distance runner presents with right foot pain caused by stress fracture. You're thinking about chronic energy deficit. Bone and a female athlete triad. What is the next best step? Referring to a dietitian to optimize energy balance. Starting calcium. Discontinue the sport. Using oral contraceptive pills or physical therapy. Nobody wants to give her calcium? No? Yes? Maybe? Okay? So of course, the main reason is probably energy deficit, so you have to send her to a dietitian. However, starting calcium supplementation if she's not getting enough calcium is not wrong. Sending to physical therapy is not wrong. Those are all correct answers. The only thing that usually you cannot convince them to discontinue the sport, that's number one. Even taking a break is very hard for them. They really need to have a good physical therapist and a plan to get back to the sport because that is their goal. So telling them, oh, you can't run anymore, they're just going to go find another doctor. Oral contraceptive pills, some people believe, giving them the estrogen is great, but if this is somebody with amenorrhea, especially in the setting of chronic energy deficit, I really do not like to put them on a birth control pill because you lose your marker. Spontaneous menstruation just tells us about adequate fat. And so I prefer not to put on an oral contraceptive pill or even a transdermal estrogen. There is new data coming out of Boston Children that shows transdermal estrogen has some benefit on bone mineral density, but it's really preliminary. We, again, don't have long-term data in terms of fractures or prevention of stress injuries. Everybody got all the answers correct? Okay, I'll take any questions.
You didn't talk about that's very much. Is osteoporosis developing female kids?
No, it is not. So actually the female athlete triad term is also wrong. I mean, there are males with the athlete triad, so we try to not use that term anymore. And we are looking, if it's a primary or a genetic, osteoporosis, there is no difference between male and female. It's an autosomal dominant or autosomal recessive. It's not spectrum. And again, chronic diseases causing secondary osteoporosis, again, no difference. You may say males a little bit more if you're thinking about Duchenne muscular dystrophy patients. However, there is no sex difference.
Another question. The gurus who kind of approve vitamins or multivitamins and stuff, is there a case of continuing vitamins?
You mean vitamin D or multivitamins?
Well, vitamin D.
So vitamin D, if they are not getting adequate amounts, if they don't, a lot of them are not out in the sun and they're not making enough vitamin D, and also with the use of sunscreen, sure. However, I have not seen any data saying if you put them on high dose vitamin D, you can reduce fracture risk. We don't have that. You want to bring them up to adequate levels, and that's pretty much it.
So the vitamin D level, things like everything between 9 and 10 is low. Everybody is low.
What do you use as low?
Less than 30.
Less than 30. 30 is the cutoff. Yeah, so the reason I'm asking is because every place has a different cutoff.
Right.
And, like our lab would say less than 25 is low. In some places we'll say less than 30. So yeah, I mean, whether it is because we are measuring more vitamin D, or is it that the assays have changed, or everybody is more inside and we are all very diligent about using sunscreens, I'm not sure what is the cause. I do not routinely check vitamin D levels, except in somebody who I'm going to treat with bisphosphonates. I want to make sure, or somebody where I'm trying to figure out what's going on, or I'm suspicious about rickets. And the reason is you see these levels and then what do? It's very hard to get toxic in vitamin D. I think taking 1,000 to 2,000 units daily is fine. You don't get toxic with those levels. You just have to be careful with infants, sometimes with a dropper. Instead of using one drop, we've had cases of hypercalcemia and vitamin D toxicity when the parent is giving the whole dropper. But in general, it's hard to get toxic. So I just tell people to take 2,000 units of vitamin D. I don't check. What is hardest is African American children and obese patients. And the thought is that it's a fat-soluble vitamin and that it's actually stored in the fat and you're not measuring the serum level. There is some data to support this because patients who undergo bariatric surgery improve their vitamin D after the fat is taken out. So there is something to support that. However, so I don't routinely check vitamin D levels.
Have you heard about the endocrinologist in Boston who vitamin D advocate who apparently testified in 350 child abuse in every single case that it wasn't child abuse, it was vitamin D?
Yes, a few cases have come across to our table as well, to Dr. Bacharach, then, yeah, it is, I think there is really, no data saying that vitamins, I mean, yes, if you are very deficient, you can have some bone fragility. However, the cases I think that you're describing, there were some injuries and some fractures that are very hard to explain with just vitamin D deficiency. It's very disturbing. There was also an orthopedic surgeon out of Chicago, I believe, who is just, yeah.
Bone thicker, does it help bone density?
What thing? I don't think I remember seeing any data about it, but I'll have to look more into it. I don't recall Accutane, and bone mineral density data, so I'll have to look into it. I don't know the answer. Thank you for coming. I think there is concern especially I wonder if it's coming from that.
Right.
But if they also have everything.
Yeah.
I think it has to do with that they were concerned with depositing in the bone, depositing in the cardiovascular system, increasing risk of.
I think there is some concern. I don't think
Okay.
it's not like, you take care of it, that there is a way to tie it directly to the bone from there, unless there's a bad issue. There is something floating around, but I don't think there is concrete data.
Okay.
Yeah, thank you.
Sure, thank you.
Scary.
To regulate women to have periods, but that's okay. It's not a normal period.
I mean, there's,
You don't have the.
Oh, the ration and the thickening.
So the thickening